Okay,
Okay, what was I? Where am I?
we
Okay,
are on the question number two explanation.
yeah. Common obsession are related to cleanliness, symmetry, harm, self to others, and yourself. Taboo thoughts and idea compulsions are rigidly applied repetitive behavior like checking, washing, or mental activities like counting or repeating words that relieve the anxiety related to obsession. Some patients demonstrate both obsessions and compulsions. Other patients experience either obsessions or compulsions. OCD typically presents early in life. It's commonly treated with CPP and SSRI such as paroxetine. Domipramine and venlafaxine are second line medication options. Next.
Okay. One day after undergoing an elective cholecystectomy, a 72-year-old woman, a 72-year-old woman become confused and bel, belligerent. She has 2-year history of mild dyspnea and Alzheimer's disease. He takes no medication. Intramuscular haloperidol is administered. 1 hour later, she begins to repeatedly hyperextend her neck. She has repetitive conjugate upward movements of the eyes that she says she cannot control. Examination shows no other abnormalities. Which of the following is the most appropriate current symptoms?
Ready?
1 second, please.
Mm-hmm.
Okay.
So it is dopamine blockade, acute dystonia, involuntary painful muscle spasm that occur most frequently in the response to D2 antagonists such as typical antipsychotics like haloperidol. It's postulated that an imbalance of dopamine movement facilitator and acetylcholine movement inhibitor in the nigrostriatal pathway contributes to um, acute dystonia. One presentation includes torticollis, head tilted to the side or down, retrocollis, head at the back, opistotonis, arching of the back, oculosis. Involuntary deviation of the eyes. Patient rarely present with laryngosspasm or stridor. Underlying pathophysis imbalance in dopamine cholinergic pathways of the basal ganglia. These factors for development include male sex, young age, recent cocaine use, history of previous acute dystonia reaction are treated with anhydramine and benztropine, which are both anticholinergic medication that restore the balance in the dopaminergic and cholinergic pathway. It's not being acetylcholine excess is not associated with acute dystonia. It's thought that an imbalance of dopamine and acetylcholine contributes to acute dystonia, though dopamine antagonism much more commonly leads to acute dystonia reaction. Okay.
Okay, next. A 27-year-old man comes to the physician because of sadness and difficulty falling asleep since he and his wife separated 3 weeks ago. He has had no changes in energy or appetite. He enjoys spending time with his friends, which he says distracts him from the separation. He is hopeful that he and his family will work through their conflicts with therapy and time apart. He has no history of serious illness. His sister has major depressive disorder, well controlled with certain physical examination of the patient shows no abnormality on mental status examination. His mood is sad, he is tearful, his thought process is logical. There is no evidence of suicidal ideation or hallucination. Which of the following is the most likely diagnosis?
Ready?
Is it acute stress disorder
I do not think so,
or
but
it is adjustment disorder? You are thinking
I,
about MDD.
no, I'm thinking adjustment. But
Adjustment is within 1 month, isn't it? Or less than
um,
3 months. Okay,
and
let's see.
it is adjustment that refers to the onset of emotional disturbance within 3 months of an identifiable stressor. The emotional disturbance manifests as marked distress out of proportion to the stresses and significant impairment in the daily school, work, or social functioning. Adjustment disorder are typically associated with anxiety, depression, behavioral symptoms without meeting the criteria of anxiety or depression. For example, this patient demonstrated a sad mood and insomnia, but no anhedonia and changes of in appetite or energy. As adjustment disorder is typically self-limited, the treatment includes supported psychotherapy, but may also include symptomatic treatment with and symptomatic treatment of anxiety and depression with like sleep medications. Next,
An 18-year-old woman is brought to the office by her mother. An 18-year-old woman is brought to the office by her mother for a pregnancy test because the patient claims that she is carrying the child of a famous she is carrying the child of a famous rock star. She says she had not told her parents about the relationship because of her boyfriend's need for privacy. She also says that he cannot call her at home but has regularly talked to her through the television newscaster during the past week. Her excitement at becoming pregnant prompted her to tell her parents. During the past 2 months, they have noticed behavioral changes in their daughter, including collecting pictures of the star, spending excessive amounts of money on makeup and clothing, sleeping little, and becoming increasingly impatient and demanding with her family and friends. There is a family history of type 1 diabetes mellitus, major depressive disorder. The patient's temperature is 37 degrees Celsius, pulse is 73 per minute, blood pressure is 105 by 68. Examination shows no abnormality. Results of the lab studies are within the reference. A pregnancy test is negative. Toxicology screening is negative. When told that she is not pregnant, the patient is adamant that the test results are wrong. Which of the following is the most likely diagnosis?
ready?
Is it OCD?
I do not think so.
Let's see. What's your thought?
I'm thinking more bipolar.
Okay. Where is the manic?
She thinking that some celebrities is in love with her.
Okay. Okay, you are maybe right.
Ready?
Yes. Yes, you are right.
Okay. It's bipolar. This patient is experiencing an episode of acute mania and can therefore be diagnosed with bipolar. Bipolar mood disorder that features acute episodes of mania may include episodes of depression. Acute mania typically manifests irritable and euphoric mood, increased energy, decreased need for sleep, increased goal-directed activity, rapid speech and thinking, responsibility, grandiose thinking. Some patients demonstrate associated side symptoms like erotomanic delusions, hallucinations. Acute mania can severely disrupt patients' daily function and endanger safety. Management of acute mania requires mood stabilizer therapy, And most stabilizer or atypical antipsychotics. Okay, next.
Yes, a 47-year-old man with alcohol use disorder is brought to the emergency. He is brought to the emergency department because of double vision and inability to walk for a day. Examination shows sluggish pupillary response and a horizontal nystagmus. There are palsies of the lateral rectus muscle bilaterally. He is oriented to place and time. He falls when attempts to walk. On the most likely cause of this finding of deficiency of which of the following?
Ready?
Yes, yes, ready.
Yes. So it's B1. Alcohol use disorder typically
Can you hear me?
have a significant. Yeah, I can hear you. Can you hear me?
Yes, now I can hear you.
Patients with alcohol use disorder, significant B1 deficiency due to not eating, thiamine malabsorption in pets, whatever. Over time, thiamine can result in damage of an atrophy of the mammillary bodies visible on MRI, which is Wernicke encephalopathy, which presents as a tired altered mental status, nystagmus, and ataxia. Patient may present physical findings, blah, 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 findings and labs consistent with cirrhosis, such as gynecomastia, palmar erythema. Symptoms of Wernicke are reversible, but increase the risk of developing Korsakoff psychosis in patients with alcohol use disorder if not treated with thiamine. Where Wernicke-Korsakoff syndrome is irreversible condition that features anterograde retrograde amnesia along with the consequent tendency to confabulate, verbalize false stories and memories to compensate their inability to remember. Next. Next.
Yes, can you hear me?
Yeah.
Oh, sorry. A 42-year-old man a 42-year-old man is brought to the office by his wife because of 1 month history of progressive irritability and paranoia. His email his email to her yesterday contained violent song lyrics and uncharacteristically rambling and paranoid statement about his parents. 4 months ago, he bought a handgun. He has never threatened to harm anyone. His wife says that she feels safe but worries that he will unintentionally do something stupid. She says she has always acted grandiose and promotes himself as a rock band manager because he is really just a group pie, just a group pie. He is currently angry at the local rock band that he says owes him money for his services. His parents financially support him, his wife, and 2 children. He has no history of serious illness, takes no medication. On examination, he is cooperative, occasionally scans. He is cooperative, occasionally scans the room, blinks every 3 seconds. Vital signs are within normal limit. Physical examination shows no abnormality. On mental status examination, he has an annoyed mood and blunted affect. His thought process is circumferential. His answers are long and complex. When asked about the email of his wife, he laughs and says she misunderstood it. He reports no hallucination or suicidal or homicidal thoughts. He is un he is unable to recall 3 out of 3 items after 2 minutes and is fully oriented. Which of the following is the most appropriate next step to reduce the patient's potential danger? to himself, to others.
Ready?
Yes,
So it's arranged to remove the weapon from the patient's home. This patient has several acute risk factors for suicide and homicide, indicating that his access to lethal means should be restricted. His acute risk factors for homicide include paranoid ideation, increased impulsivity, and possession of firearms. It's also concerning that the patient is demonstrating a preoccupation with violence, as evident by his song choice. The acute risk factors for suicide include increased impulsivity, possession of firearms. Even that the patient has multiple acute risk factors for suicide and homicide, psychiatric hospitalization should be considered. However, given that the patient has not threatened violence and denies current suicidal ideation, it's reasonable to create a patient safety plan. An important element of safety plan is restricted the patient access to lethal means such as firearm. The physician should attempt to obtain buy-in from the patient to dispose of or restrict his access to firearm. After attending to the immediate safety risk, antipsychotic medication should be started if the patient is agreeable, and the cause of this patient's psychotic symptoms should be elucidated. It's not the notify the parents and the rock band about the potential danger is not needed at this time. The patient has not expressed of suicidal ideation or specific threats towards the parent or the rock band. Next,
okay. A 19-year-old, a 19-year-old man who is a college student. A 19-year-old man who is a college student comes to the office because of 1 year history of progressive feeling 1 year history of progressive feeling of anxiety when he uses stairs or drives when he uses stairs or drives an automobile. He reports that when he climbs a when he climbs a flight of stairs at school, he becomes afraid he will kick something onto the stairs that will cause someone else to fall. When he drives over a bump in the car, he is afraid that he ran someone over. In both situations, his anxiety and fear build until he returns and checks to ensure that no one will hurt. He often has to repeat this behavior several times. He says that he has been late for class on numerous occasions because he avoids staircases. He reports that he has few friends and prefers the company of his parents. His parents are aware of his symptoms and have encouraged him to seek help. Physical examination shows no abnormality on mental status examination. He appears mildly anxious and expresses concern about accidentally hurting someone. Which of the following is the most likely diagnosis?
ready?
1 second, please.
Okay.
Ready.
So it is OCD manifests as recurrent intrusive urges, thoughts, obsessions, as the patient tries to relieve or neutralize by repetitive rituals, compulsions, common obsessions. We already know cleanliness, symmetry, harm, whatever compulsions. We know those. The symptoms are time-consuming and cause significant anxiety to patient and markedly impaired functioning. Patients with OCD also commonly experience anxiety and MDD. Oh, sorry, related major mood disorders. OCD typically presents relatively early in life, in most cases by age 20. It's commonly treated with CBP and SSRI, clomipramine and velacifency. second line options. Next. Next.
If, yes, a 14-year-old girl 14-year-old girl comes to the clinic for a pregnancy test. She is not sure about the date of her last menstrual period. She has been sexually active for 6 months and she and her sexual partner is occasionally use condoms. She does not use contraception because it has not happened yet. I don't really think I could. Yes, I don't really think it could happen to me. He thinks that she cannot get pregnant without an. She thinks that she cannot get pregnant without an orgasm. She will not use contraceptive jellies or spermicidal foams because they are gross. These patients' behavior and statements illustrate which of the following characteristics of the adolescent development.
Ready?
1 second. Ready.
A sense of invulnerability. This patient demonstrates a sense of invulnerability consistent with the principle of adolescent egocentrism. According to Piaget's stages of cognitive development, adolescents enter the formal operational stage and begin thinking abstractly, using logic rather than relying on direct observation. Hmm. When they enter this stage, they experience their thoughts as powerful and begin to direct their thoughts inward toward themselves, egocentrism. Since adolescents still have difficulty differentiating their own thoughts from other thoughts, they presume that others are focused on them as well, causing them to believe their experiences are unique and special. This sense of uniqueness is hypothesized to contribute to sense of vulnerability to risks such as consequences of unprotected sex or death. Research studies on the validity of this theory of adolescent invulnerability has been mixed. Piaget's stage of cognitive development describes the ability of children to use thinking and uh, use thinking and learning to navigate the world. The stages progress over time across the sensory, motor, pre-operational, concrete operational, and formal operational stage. It's not abstract thinking. Is beginning to develop in adolescence. Is beginning to develop in adolescence. However, the lack of fully developed abstract thinking deters these patients from considering the similarities and differences between their thoughts and other thoughts. As described above, this type of abstract thought leads to an inability to fully appreciate risk. And it's not delusional think. Wait, was I delusional thinking that I was thinking? Yeah, delusional thinking involves fixed false beliefs. This patient does not convey complete certainty in her belief that she will not become pregnant. Okay. And then wait, concrete thinking refers to reasoning based on perceptual information about the physical world. This patient demonstrates degree of abstract thinking in that she can consider. Okay. Next.
Yeah. An 18-year-old girl is brought to the emergency department. An 18-year-old girl is brought to the emergency department by her friends 20 minutes after losing consciousness at a party. Just before losing consciousness, she began to slur her words. Her friends say that her friends say that uh, There were alcohol, benzodiazepine, hallucinogens, narcotics, stimulants at the party. They think that she was using one of the substance, but they do not know which one. Her temperature is 37 degrees Celsius, pulse is 68 per minute, respiration 9 per minute, blood pressure 90 by 60. He responds to external rub with moaning and is unable to answer questions. The pupils are 1 to 2 millimeter and minimally reactive to light, which examination shows no nystagmus or involuntary movements. Use of which of the following is the most likely cause of this patient's finding?
Ready?
1 minute. Okay.
So it's heroin. This patient is likely intoxicated with heroin opiate drug. Opioid, which are CNS depressants used as analgesic and recreational drugs, act through the CNS and peripheral nervous system, interact with several neurotransmitters leading to diverse effects. Opioid intoxication causes euphoria due to interaction with dopamine, altered mental status, sedation, bradycardia, hypotension, depressed respiratory tract, constricted pupils. Meiosis is distinctive finding that is less common in intoxication with other CNS depressants and is caused by direct opioid receptor activity in brain areas responsible for pupillary constriction. Pupillary control. Opioids also act on receptors within the enteric nervous system, decreasing gut motility and causing constipation. Next.
Okay, can we stop here because I am doing plenty of missing. My brain actually not working.
No worries, no worries. Let's just finish this tomorrow. Okay, I'll see you tomorrow.
Okay, we will take break from tomorrow.